Hi, you guys. My name is Victoria, and I am a BSN-RN student. I currently go to WGU, Western Governors University, and I'm halfway through my nursing program. So today I wanted to talk about a very important topic, therapeutic versus non-therapeutic communication. So therapeutic and non-therapeutic communication, this is used in our psych and mental health facilities, often with these patients who we require a lot of interaction and gathering information from them. So therapeutic communication, the goal is that we want to establish trust with our patients. We want to build that rapport so that they feel that they can talk to us and open up about their thoughts, their feelings, their mood, their concerns, and the issues that they're dealing with. So by creating that feeling of trust, knowing that they're in a safe environment, by us letting them know that we are there to help them, it really encourages that sense of communication and the ability to grow on that communication. So our number one priority in therapeutic communication, this includes the verbal and nonverbal communication, but our number one priority is to establish safety. So we want to let our patients know that they are safe with us, okay, that they are going to be taken care of. And so by providing an environment that is going to be low stimuli if needed, so that means not having bright lights on, not having loud noises, not having a lot of people, so maybe putting them in a private area, things like that really can encourage that therapeutic communication, okay? So we, with our therapeutic communication, it includes verbal and nonverbal. Some of the nonverbal communication can be some of the biggest indicators of whether our patients will communicate with us. Because if we're standing there with our arms crossed and we have a closed off posture, or we kind of have a judgy look on our face, that's going to prevent our patients from feeling like they can openly communicate with us, right? Okay, because we would want someone that's going to be intentional in listening. So we are going to actively listen to what they're saying, okay? We're not going to interject. We are going to take the time to allow them to have their thoughts and gather them and then ask questions when it is appropriate, okay? So there is something that is called the duty to warn. Duty to warn is whenever a patient tells us something that we don't need to keep amongst ourselves, okay? So we have to inform our patients that we are not going to be keeping secrets, that things are not going to be kept just between us. This is for the protection of their safety and the safety of others. So duty to warn is whenever an individual tells us something like that they are planning to harm themselves or harm someone else. So say a patient comes in and they say something like, oh, just wait till I get out of here. I'm going to kill my spouse. So we have a legal obligation as the nurse to inform the other healthcare providers so that that can be documented and that can be dealt with. And then if a patient says something like they are trying to harm themselves or someone else, we are immediately going to make sure that we have one-on-one supervision. Whether that means if that we cannot get someone to come sit with that patient right away, we are going to be like, hey, come with us to the nurse's station. Let's go for a little walk. We're going to find someone that can watch them, but we're going to not let them out of our sight in that process of doing so, okay? They're going to come with us to the nurse's station. They're going to come with us to the bulletin board. They're going to follow us around so that we can kind of keep a close watch on them, okay? Until we can get someone to make sure that they are safe and going to be okay. So another thing that's important with nonverbal communication, this can include things like clothing, tattoos, body language, makeup, the way a person expresses themselves, how they're sitting, if they're closed off or if they kind of have an aggressive posture. So those are important things that we need to recognize in ourselves and evaluate as nurses, how we're coming off to the patient. Also, another important thing, you never want to just touch a patient without warning them or letting them know, hey, is it okay if I touch you? Especially in our schizophrenic or personality disorder patients, it can kind of be alarming. It can seem threatening to them. So they may try to swat at you. So it's really best to let them know, hey, I'm going to touch you now. Is that okay? So some important therapeutic techniques. So when we're establishing that trust, we want patients to be able to open up and talk with us. We're going to not ask yes and no questions, okay? Because those are called closed-ended questions. We want to stay away from closed-ended questions because these they don't allow you to get more information, okay? So you might ask someone, do you want to hurt yourself? And they say yes. Okay, well now you have to ask another question to get more information. If we ask open-ended questions like, how do you feel this way? When did this start? If the patient says, I have been wanting to harm myself, or I have had thoughts about ending it all, you could say something like, I hear what you're saying. Tell me more about that. Or can you tell me more about that? So you're giving them the opportunity to open up and delve further. You're giving them that opportunity to communicate and to tell you their thoughts without probing or without making it be on your terms. So something that's important also, there's several different therapeutic versus non-therapeutic communication techniques. So some of the important things that we really want to focus on includes things like making sure that our patients know that they are in a safe environment. We can use techniques like silence. Silence is a really big one. It seems really simple, right? But it allows our patient to just know that we are there for them, that we can just sit with them, we can allow them to think, to gather their thoughts, and then talk with us when they're ready, okay? So accepting is another technique. This is used to let our patients know that we are there for them and that we are not providing a judgmental manner. We're going to come to them with a non-judgmental approach to meet them where they are at, to provide the care that they need. So another one is giving recognition. So we never want to give our opinions to patients, okay? We want to just provide the facts. So our goal is not to give them our opinion, because we want them to come up with their own thoughts, their own feelings, be able to manage their care themselves and use autonomy, which autonomy is the ability for patients to make their own decisions, okay, right? Because they have that right and that ability. So we want to give them that tool that allows them to make those decisions. So we're not going to give our opinion, okay? We're going to keep it to ourselves. But by giving recognition, we can say, for a depressed patient, for example, I see that you showered today. By stating that you made that observation, you are essentially saying, I see that you did a good thing. You took the steps to take care of yourself and provide that self-care. So another thing is we are just offering ourselves. So we are just saying that we're there. If you need something, I am here to help. Another thing is giving broad openings. So this allows the client to kind of select the topic of what they want to say. So we can kind of let them explain their thoughts and their feelings. Another thing is giving a general lead. I've already kind of touched on this, but giving a general lead is when you say something like, tell me more about this. Tell me more about blank. Tell me more about your thoughts at home. Tell me more about your thoughts in the workplace. Tell me why it is hard. Not tell me why, but tell me more about such subject. Another thing is placing events in sequence. So kind of getting a chronological order of when a patient started to feel a certain way, or when these symptoms first started to occur. So some other things are restating. This is used to confirm what the patient is saying and that you understood what they're trying to communicate to you, okay? Another thing is focusing. So we might have a patient that's kind of staring out the window, and we can say something directive to kind of focus them in on a specific statement that they said or a specific thought or feeling that they're experiencing. We can get them to explore those feelings by focusing on something specific, okay? So seeking clarification. So we might say, I heard you say this. Did you mean this? And then say what they said to make sure that you're understanding what they're saying so we can interpret their words correctly, okay? So presenting reality, we often use that in personality disorders because we want to make sure that our patients know the environment that they're in. So we might clarify whenever a patient is having a hallucination or they might be hearing voices, we might clarify and say, I don't hear those voices, but so presenting that to them in a way that I don't hear those, but I know that you do, and they're not real, okay? So some other non-therapeutic techniques. So let's talk about the flip side. So things that we don't want to do in psych and mental health because these are not good communication skills. They will not allow us to gather more information and to assess the situation, okay, and assess the needs that our patient has. So we want to stay away from these because these do not allow open communication and do not allow you to foster that relationship with your patients, okay? It's just going to hinder it. It's going to cut it off, okay? And we don't want that. So another thing I already said, but we do not ask why, okay? You don't ask why. You don't need a patient to feel threatened or to feel like they have to give you reassurance, like they have to justify their reasonings of why they feel or why they're acting the way that they do, okay? Because that puts that patient on high alert, okay? So we don't want to do that because if we do that, that's going to send them into defense mode and we're not going to get anything good out of that, okay? So giving false reassurance. So we do not want to do this. We don't want to say things like, you'll be better tomorrow. If you just take your meds, you'll be better. Because that's pushing our wants, our opinions onto them. And they might be dealing with their condition until they find the good adaptive coping skills that they need and they get on the right medication because some medications take, at least 4 weeks to kick in. So we don't want to give that false sense of reassurance, okay? We don't want to do that. We just want to offer facts, okay? So we don't want to say, don't worry, it'll be better tomorrow. We don't want to do that, okay, you guys? So rejecting. We don't want to reject a client's behavior or what they're saying because that's going to put them in a position of negativity, and we don't want to do that, okay? So let's see. We don't want to approve or disapprove of their actions or their thoughts, okay? We don't want to do that. We are just, like I said, giving the facts, okay? I want y'all to remember, we give the facts in mental health, okay? Yes. Commit that to memory. It's important. Okay, so we don't give advice. I already said this earlier in the beginning, but I want to reiterate it because it is so important, you guys. It is not our place to give advice, okay? That is not our place. We're not supposed to say, if I was in your shoes, if it was my family, I would do this. We are not supposed to do that, okay? We want our patients to be able to be independent individuals who can go back into society after they get the treatment that they need and that they can cope, that they use effective coping skills, that they are able to make decisions for themselves, okay? Because some of our patients, they are really indecisive. They have a really difficult time. Our OCD, obsessive compulsive patients, and our patients with GAD, generalized anxiety disorder, it might cause severe anxiety. You probably hear that car alarm in the back. I'm sorry. But they might feel that there's a lot of pressure and it might cause a lot of unnecessary anxiety if they can't make those decisions. So we want to give them the tools and encourage them to make those decisions. So that's why we refrain from giving that advice, okay? Another thing, we don't want to probe. So by probing, we are pushing further than the patient wants to divulge, okay? So it is on their terms. We are allowing the patient to communicate with us, to divulge things that they want to tell us, okay? If they're not ready for it, we're not going to push any further, okay? So some of our patients, our PTSD patients, are patients that have gone through traumatic experiences, sexual assault, things like that, abuse, spousal abuse, family, domestic abuse, child abuse, things like that. We don't want to probe because we don't want to breach a subject and breach their trust of feeling like they are no longer in a safe environment, okay? So we want to give them the floor to communicate when they are ready. But we do that by asking open-ended questions. Tell me more about this. Let's explore this. You said this. Let's talk about it. Okay? Does that make sense? So another thing, defending. We do not want to make our patients feel like they have to defend themselves, right? Let's see. We don't need an explanation, okay? We don't want them to have to feel like they have to give us a reason, okay? Because with a lot of these mental illnesses, they are struggling with so much. They are struggling with their thoughts, with their mood, with their feelings, how to cope like a normal human being, okay? And they are dealing with a lot of loss, a lot of feelings of confusion, grief, anger, low self-esteem. So we don't want to make them feel like they have to give us a reason why they feel the way that they do and why they have the illness that they have, okay? Because we are essentially there to help them, right? Another thing, we never want to belittle their feelings that they are saying, okay? We never want to belittle them because to them, they are the most important thing in the world, right? Okay, when you have a patient come into the med-surg floor, whether they have a really bad sprained ankle or they have mets to the liver, okay? No matter what it is, to that patient, it is the most important thing in the world, okay? A patient 2 doors down might be dealing with something that in the medical world is so much worse, but to that patient, it is the biggest thing in the world, okay? So we want to treat it as such because every patient deserves justice. Every patient deserves benevolence, right? Every patient deserves to be treated equally, to be treated fairly, to be treated with compassion, with empathy, okay? Every person deserves to be treated the same, no matter what their diagnosis is, no matter what their condition is, okay, right? So that's super important. So we want to make sure that we are not belittling their thoughts, we're not belittling their emotions, okay? That we are just simply there to let them know that we are there to help them. And that we hear what they're saying, okay? And we're going to work towards goals together to get them where they need to be, right? And to get them the help that they need so that they're in a safe place. So another thing, we are never going to interpret. So we are never going to try to interpret their thoughts and say, I think you said this, I think you said that. Okay, I think this is what you mean by your thoughts, okay? Because that's putting words into their mouth. That's putting feelings into their mouth that we might take and turn it into we might turn it into a judgy circumstance, and not intentionally, but that's human nature, right? So we want to stay away from interpreting, okay? So these are all super important things. Another thing that we do not want to do is we do not want to introduce unrelated topics. So we do not want to turn the conversation onto ourselves. So we do not want to bring up a situation from our past, from our story, to try to relate to them, right? We don't want to do that because that turns the communication onto us. And we are trying to keep it on the patient. So that is our goal. So we do not want to introduce unrelated topics because we want the patient to lead that topic. So these are some differences between therapeutic and non-therapeutic communication that is especially used in our psych patients. Again, I want to reiterate that our ultimate goals with our psych patients is to make them know that they are safe, that we are going to take care of them, that they are going to get the help that they need, that we are here to listen to them, we are here to help them. We are going to not offer a judgmental attitude. We are going to be open, and we are going to provide empathy, not sympathy, for our patients. So with the holidays coming up, I know it can be a very stressful, very difficult time for not only our patients, but for a lot of people. And so I just want to, on a more serious note, say that if you are struggling or you're dealing with loss of loved ones around this time of year, or you are dealing with a lot of uncertain feelings, a lot of anxiety, sadness, stress, if you feel depressed or alone, there are many people who you can reach out to get help from. And there are people who are here that love you and that are here to help you, because you are not alone. And we all have these feelings. You are not alone. You are not the only person that feels this way. So I want you to be able to reach out if you have some feelings or some thoughts that you needed to discuss with someone. You can talk to counselors. You can talk to helplines. You can send me a message. If you have any questions about this video, any topics that I didn't touch on about therapeutic versus non-therapeutic communication that you would like me to go over, if you just need a friend, I am here for you, because nursing school is hard and we don't have to do it alone, you guys. I know it's hard, but I am here to help you. So I want to wish y'all all a great day. Good luck studying, and I will talk to y'all soon. Bye. Also, y'all can follow me at NursingPinchofPeace and Patience on YouTube, Pinterest, and Instagram. I also opened an Etsy shop sharing my notes to help nursing students like myself and like you get through it. So that's all. Bye.